Hi, welcome back to my channel. So in this video, I'm going to talk a little bit about trauma and pregnancy. It's a little bit of a different format, more of a presentation rather than typically what I do. Let me know what you guys prefer. And remember, this is purely for educational purposes and is not a substitute for professional medical advice, diagnosis, or proper treatment. Okay, so trauma and pregnancy is significant because you're not only caring for one patient, but you're caring for two patients. Roughly 6 to 8% of pregnancies are affected by trauma, and most of which are actually domestic violence, accounting for around 8,000 of 100,000 live births, next followed by MVCs, and then falls lagging behind. So it's important to understand the nuances of pregnant physiology to guide trauma management and saving, hopefully, both of these lives. So another important aspect of trauma during pregnancy is that you're allowed to call your OB colleagues to help you during this part. As you'll see, different testing requires, your OB colleagues' professional hands-on experience. So understanding what is normal for a pregnant patient is key to understanding what is abnormal and signs of impending, whether that be cardiac failure, respiratory failure, hemorrhagic loss, so forth. So first, let's look at the labs and so forth. Okay, so during pregnancy, the plasma volume increases by up to 45%, with the RBC volume only accounting for 15%. So this relative decrease in hematocrit can actually mask hypotension secondary to blood loss in terms of your labs. And then remember that the fetus and the uterus can sometimes compress the IVC, reducing the preload of the cardiac, reducing cardiac output by up to 30%. So when able, place these patients in a left lateral decubitus position. You can also notice that when you get labs on these patients, you might notice a mild leukocytosis, a thrombocytopenia, an increased fibrinogen, maybe clotting factors. And it's important to keep these factors in mind due to that relative dilution that we had talked before. Remember that for patients, that are pregnant, they have an increased tidal volume, but decreased functional residual capacity, which leads to a chronic compensated respiratory alkalosis. And because of its chronic nature, you'll also see compensatory metabolic acidosis. So if you see a patient, that's pregnant and they have an almost normal PCO2, this could, signal impending respiratory failure and may indicate that this patient either needs, increased supplemental oxygen or just, something that will increase their ventilation. So, you may need to intubate them or you need to do, BiPAP or so forth. Generally, a good rule of thumb is to provide these patients with supplemental oxygen when they come into the trauma bay. Remember the anatomical changes. During early pregnancy, the uterus is shielded by the pelvis during the first 12 weeks. So usually, injuries and traumas don't directly affect the fetus. So treat these patients as you would any other patient. But with late pregnancy, you have to understand the anatomical changes that accompany it. The uterus gets larger, it thins out, and the fetus is less protected, meaning the fetus is more likely to get injured as compared to the mother, in terms of abdominal injuries, that is. So during term, the fetus can also transition to a vertex position with the head in the pelvis. So with car crashes or deceleration injuries, look for fetal skull fractures. Due to the elevated diaphragm, two things to consider is if you have penetrating injury to the lower thorax, this should raise concern that this could still be intra-abdominal. This is a big concern, for placing chest tubes, as if you place it in the normal, fourth and fifth intercostal space, there is a possibility that, aiming low, you could enter the intra-abdominal space. So try to go high if you need to go a little bit higher in terms of rib spaces, really trying to avoid the intra-abdominal space. Okay. Remember that these patients, because the uterus is pressed up against it, will increase the stretching of the abdominal wall, impeding the contact, and so signs of peritonitis, such as rebound and guarding, may be less prominent in these patients. And hemorrhagic shock is a major concern for these patients, especially with pelvic injury, as now the uterus occupies such a high volume of cardiac output. So what do you do when a patient first comes in with, trauma and they're pregnant? First, do your A, B, C, D, E, F, your ABCs of trauma, right? Airway, breathing, circulation. It is important to remember that the best initial treatment of the fetus is going to be optimal treatment of the mother. Next, you may want to consider visual examination using the speculum to evaluate for bleeding or leakage of amniotic fluid, for which either you could do it or your OB colleagues can help with this visualization, and it will serve as part of your exposure during the primary survey. Next, these three things can almost be done at the same time. Definitely kind of enforcing this, addressing if this is a viable pregnancy through either asking about it or getting an ultrasound to measure the biparietal diameter. Usually the number here to remember is 58 millimeters, okay? Then obtaining a fast and obtaining a fetal heart rate. Remember that the normal value is around 110 to 160 beats per minute. Next, get a CT of the patient if it's indicated, the same indications as in a non-pregnant patient, and many studies have shown that the relative amount of radiation outweighs the risks of fetal injury or fetal radiation as compared to maternal, the risk of maternal injury. So get the CT if it's indicated and just go for it. Don't be scared. Try to protect the pelvis if you can at times at the CT scanner if possible. Next, when you can come back, you can get a fetal fast, which I'll talk a little bit about on the next slide. And then the last thing is called a KB test, which is essentially the mixing of maternal and fetal blood, which can be a predictor of preterm labor. And this is also your indication to give the RH immunoglobulin to prevent alloimmunizations in the future. So what is a fetal fast? You look at the number of fetuses and their position, their placental location, amniotic fluid volume, fetal cardiac activity, and femur length. And if any of these are normal, your OB colleagues can do a more formal obstetrics ultrasound. The big thing in terms of operative trauma is when to do a C-section. So C-section or no C-section. I like the little graph on the top right. It's very simple, right? If the fetus is alive, is there evidence of fetal injury? And is it a viable pregnancy at this point, right? If all of these are yes, do the C-section. If any of these are no, then, move on, focus on the mother, ask yourself if you have adequate views of whatever injured part in their abdomen. And if you don't, take out the uterus. And if you do, leave the uterus alone. Unless it's damaged, you may want to consider repairing it and leaving it in situ. These are the other indications for doing a C-section, such as persistent maternal shock or severe injuries and a pregnancy that's near term. Generally, greater than 24 weeks or 34 weeks would be ideal. Pregnancy is a threat to the mother's life, such as hemorrhage or the mother is in the IC. Mechanical limitation to life-threatening vessel injury, which we talked a little bit about before, where you're already operating on the mother. The risk of fetal distress exceeds the risk of immaturity. Direct intrauterine trauma is an indication to do a C-section. And then special consideration, again, surgical exposure, saving the mother if CPR has not been effective. And then the last thing is perimortem C-section, where really the survival rate is only okay if it's within 5 minutes of the mother's death. So otherwise, uninjured fetuses, they have, pretty worse neurological outcomes or just low survival rates if done after that 5-minute window. For stable and non-operative patients, especially, they should be monitored with fetal heart rate and their uterine contractions for at least 2 to 6 hours, and most practitioners will go for around 4 hours at least. These are your indications to observe them for a minimum of 24 hours. This includes abdominal bruising or other obvious abdominal injuries, persistent abdominal or uterine pain, maternal heart rate greater than 110, regular contractions, vaginal bleeding, coagulopathy, such as low platelets or fibrinogen. If there's a high-risk mechanism such as vehicle ejection, motorcycle, death of another occupant in an MVC, or evidence of placental abruption on ultrasound. So what is placental abruption? It's rather common. It happens even in minor trauma and very common in severe trauma. And you may not always notice this. Their symptoms can be vague. It can be just abdominal pain, contractions. Sometimes you can see vaginal bleeding depending on exactly where the placenta is located and how much of the placenta has the abruption. There's no single diagnostic test, although imaging can be very helpful and sometimes can pick up this diagnosis. So focus on the constellation of symptoms, constellation of lab findings, whether they have a hemoglobin drop, and then look at their imaging, see if you can find any type of placental abruption there. Treatment may be C-section if indicated, or observation, and then normal delivery or C-section later on as decided by your OB colleagues. The big next thing that we often see is uterine rupture. It can occur with severe blunt trauma or with penetrating trauma. Usually presents with shock, abnormal fetal heart rate tracings, uterine tenderness, vaginal bleeding, or palpation of fetal parts outside of the uterus. Diagnosis is usually made by imaging. You may see it on a CAT scan, or you may even see on your ultrasound, or if the patient is deteriorating and you're taking this patient for an emergency XLAP, you could see uterine injury or uterine rupture there, and consider either taking out the uterus or performing a C-section and trying to calm things down. Remember, a buzzword is that the uterine rupture typically occurs in the posterior fundus, so make sure to look back there for any injuries. If uterine rupture occurs after delivery of a child, make sure to aggressively resuscitate the patient, even in shock, as the uterus will eventually clamp down and will be closed off. What I mentioned a little bit before was the fetal maternal bleeding. This is often asymptomatic. It happens around 30% of pregnant trauma. Usually the diagnosis is a KP test, and the results of that is what we learn a lot about in med school is maternal alloimmunization, preventing antigen formation or antibody formation, which can be dangerous towards future pregnancies, but also can be a cause of fetal anemia and fetal death. There's a few case reports on amniotic fluid embolism, but there's no large analysis. But with those case reports, they've talked about severe respiratory distress, hypoxia, seizures, DIC, and sudden cardiovascular collapse as things that you may find acutely happening to your patient if there's a concern for amniotic fluid embolism. I just mentioned this case report here, which looked at, a 35-year-old female that was 34 weeks and 2 days gestation after an MBC. had no significant abdominal findings except for a seatbelt sign, and then developed some abdominal pain 2 hours later. Even then, they did an ultrasound which did not show a placental obstruction. However, a 2-gram drop in your hemoglobin prompted the patient to undergo a C-section, where it found to have a 20% abruption with nearly a liter of blood loss because of it. At this point, the newborn did have, a worse neurological outcome. So remember that, domestic violence is your number one cause for trauma in pregnancy, so don't forget to circle back to this before you discharge the patient back to their same environment. Look for things like cuts, bruising, burns that do not match the reported mechanism of injury. Look for bruises or injuries in various stages of healing. Look for restraints or grip marks or repeated injuries. These can be little clues that help you kind of ascertain the truth, and then report all of the suspected cases to the appropriate agencies, and utilize social work and case management to try to get them to a more safe place as they are discharged later on. All right, that is kind of the video. I hope this was helpful. Make sure to leave a comment, like, subscribe. Please tell me, which type of format is more entertaining, and I can try to kind of appease that, if you will. Thank you for watching, and I'll see you in the next one.